Welcome to the case presentation 3 session of compressed PCI. I am Kyoung-Ha from Hanbit University of South Korea. Our co-moderator is Dr. Ashok Seth from Fortis Hospital of India. We have 3 panelists, Dr. Yuji Hamazaki and Dr. Hanbit and Dr. Euihong. Today we have 5 interesting cases of complex PCI. The first presenter is Dr. Dian Setiawan from Indonesia. He will present about the balloon trapping technique at the Antegrade guiding catheter. May be helpful if gears cannot cross the CTO retrograde approach. Dr. Setiawan, please.
Good afternoon, my name is Dian Setiawan, fellow from Pinawalaya Cardiac Center, Indonesia. Thank you very much to all panelists and moderator for the opportunity to present our case today. My presentation will be entitled with balloon trapping technique at the Antegrade guiding catheter may be helpful if gears cannot cross in CTO retrograde approach. I have no disclosure. PCI for CTO is challenging and has been associated with low success rate. However, recent advancement in equipment and hybrid approach have increased the success of CTO PCI. Hybrid approach CTO PCI focus on opening the occluded vessel using all available techniques tailored to the specific case in the safest and the most effective and efficient way. Now, I present a case of 64 years old female who came with progressive angina since 3 weeks before admission. She had dyslipidemia and hypertension and was already in menopause. She was treated with chronic heart failure and coronary artery disease to vessel disease with left main disease. She refused cabbage. From coronary angiogram, we can see that the CTO from the proximal to the distal RCA. The RCA was dominant vessel and the retrograde filling of the distal RCA from the septal collateral. The target, the open CTA proximal to the distal of the CTO, and we have the length more than 20 millimeter, then multiple CTO. With the distal target vessel is bifurcation. And a good septal collateral, so we plan to open the CTO using hybrid technique. Firstly, we tried with antegrade wire escalation technique, but failed because it was difficult to cross from the antegrade. We couldn't use ADR technique because distal target vessel was bifurcation. We decided to use retrograde approach from the septal collateral. The GCTO score was 2 point, and the progress CTO score was 0 point, and progress CTO complication score was 3 point. The syntax score seems gives more preference rather than PCI. Formerly, we tried antegrade wire escalation technique, but unfortunately, we failed to cross the CTO even though we escalate the guide wire from filter XTA to Kaya first and finally Kaya third. After several minutes, we decided to perform retrograde approach via septal collateral. And then we faced some difficulties here when we were crossing the septal collateral here because there was tortoise vessel at the mid part of the septal collateral. Then we changed cyan guide wire to SWO03 guide wire and successfully served through the tortoise vessel of the septal collateral to the distal PDA and then to the distal cap of the CTO. Guide wire was changed to filter XTA to cross the lesion, but unfortunately it was failed. So we escalate to Kaya 2 or Kaya second guide wire which successfully crossed the lesion through the proximal cap of the CTO and finally went into contralateral guiding catheter. We have some problem here, which is the gears, the micro-catheter or the balloon can cross from the retrograde to the antegrade guiding catheter. In order to form a supportive rail with retrograde wire, we perform balloon trapping at the antegrade guiding catheter, and thus the gears from the retrograde could cross the lesion. as the distal guide wire was fixated using balloon trap at the antegrade guiding catheter in order to make support, and then we use Ikasuchi 0 1.06 millimeter and then reagent plus 1.25 15 millimeter balloon respectively inflated at the distal to proximal part RCA. Next, several balloon was inflated from the proximal to the distal part as the vessel preparation, and continued with stent implantation from the RCA PDA to ostial RCA with overlap stent. This is the final result. So TB3 flow, no residual stenosis, nor coronary dissection. In retrograde approach, if the wire successfully cross CTO lesion and enter the antegrade guiding catheter, but other gears could not follow, trapping balloon technique may give additional support to deliver the gear crossing the lesion. Thank you.
Thank you for the nice presentation, Dr. Setiawan. Is there any comments or questions from the panelists?
So we'd request the panelists to ask any or comment first.
Okay, thank you, Dr. Dian. Very good, nice cases presentation. So can I now some trapping balloon technique? So you trap the balloon in the antegrade guiding catheter with the retrograde wire, and then you pull out the guiding catheter to advance the micro-catheter into antegrade guiding catheter. So could you describe the detail about the trapping technique? Just only trap the retrograde wire inside of the antegrade wire, or you did pull up the antegrade guiding catheter to advance the retrograde micro-catheter?
Okay, thank you, Dr. Euihong for the question. We actually have antegrade support with AL the first time. We changed to the GR, and then because the wire can cross until the antegrade guiding catheter, but the micro-catheter can cross, we have an idea which to make which is the wire more sportive with the trapping technique at the antegrade guiding catheter with a balloon 2.5 about 20 millimeter compliant balloon, and we inflate at about 8 ATM, and then in other side we have a small balloon. We try to push forward into the distal cap of the CTO, and then we inflate slowly. And then we change from the Ikasuchi 1.0 small balloon, we change to the bigger one balloon 1.25. We in order to make what is that modification plug of the distal cap of the CTO, which is we doing it retrograde attempt, sir. So
two questions. Can you clarify two questions? One is, which was your microcatheter, which was being used for retrograde crossing of the CTO? And the second question is that did you then follow that up with retrograde balloons? You said you use a 1.0 into 6 millimeter. Was that passed retrogradely, or was that antegradely to dilate the lesion, the CTO?
Okay, Prof. Ashok Seth, thank you for the question. We use microcatheter fine cross 150 centimeters, and then we push the balloon, which is we use Ikasuchi 0 from the retrograde, sir, not from the antegrade. So we modification plug the CTO from the distal part of the CTO, because we doing attempt at or approach of the retrograde, sir, so that we have power from the wire, which is we have strength from the balloon technique trap. In order side, we have to push the small balloon, which is we inflate the balloon simultaneously.
So you took the fine cross out and then put the balloon in.
Yes, of course, sir. Of course, Prof. Ashok said, of course, like that, because we can't inflate the balloon without pull out the micro-catheter, Prof.
Is there any questions from the panelists?
Yeah, this is, I have just one comment. And anchor balloon technique in antegrade guiding catheter is very popular. And we often use this technique in retrograde approach. So, and you want to get a strong backup from a retrograde side, you should use this technique. Yeah.
Thank you, Prof. Yuji Hamazaki.
Okay, let's move to the next topic. The next topic will be presented by the Dr. Hosein RB from Iran. The title is Guide Wire-induced Distal Coronary Perforation Management using a piece of coronary balloon, a novel technique. Dr. RB, please.
Hello, everybody. I'd like to share a case of guide wire-induced distal coronary perforation. I have no disclosure. The patient is a 49-year-old female, hypertensive, recent history of primary PCI on LAD. She complained from chest pain. Physical examination was normal. ECG showed normal sinus rhythm, T-wave inversion in anterior leads. In echocardiography, LV ejection fraction was 50%. Baseline lab data was normal. Left coronary angiogram has no significant disease. Previous LAD stent was patent. Right-sided angiogram, right-sided angiogram showed significant lesion at mid of RCA and severe lesion in PDA. We decided to perform PCI on PDA. The 0.014 Gallo guide wire was advanced through PDA. Pedilation was performed. Stent delivery was challenging and short drug-eluting stent did not cross the PD lesion. Wire changed by BHW guide wire, and with multiple attempts, eventually the stent was crossed and deployed. We also performed PCI on the mid of RCA by another drug-eluting stent. After stenting of RCA, a large flap of dissection was detected as well as perforation. You can see here. Balloon tamponade was started quickly. 30 minutes after intermittent balloon tamponade, there is still extravasation of contrast. According to perforation algorithm, we placed the fine cross micro-catheter in the target vessel and injected fat and thrombus several times, but it was not effective. Coil and gel foam were not available in our cath lab. Echocardiography showed small pericardial effusion. We chose a coronary balloon and cut it from around the middle. This portion of balloon was placed on the guide wire from the distal part and pushed to the target perforated vessel by another intact balloon catheter. After reaching the distal perforated artery, the balloon was fixed and guide wire was pulled back. Therefore, that part of balloon was embolized. the blood leakage was decreased. However, perforation was not completely sealed. Therefore, we did everything again and with another piece of balloon. This is a summary of this method. Step 1, cut the balloon. Step 2, place it on the guide wire. Step 3, push it with another balloon catheter. And step 4, pull the guide wire back and embolize part of balloon. This is the final result. Perforation was sealed completely. 2 balloon marker was seen in this image. The ECG showed ST segment elevation inferior lead, which was resolved after 1 day. Precardial effusion did not advance any further. She was discharged from hospital 2 days later. Advantage of this method. There is no need to remove the guide wire. The method is cost-effective. Already used balloon can be reused. It is fast. The radio-opaque marker makes determining the position in the target vessel easy. This table shows comparison between balloon and coil. Discussion points. Are there any alternative techniques for sealing the perforation when coil is not available? Is cover stent useful in this situation? What is the disadvantage of this method? Conclusion and take-home message. PCI on a small vessel would increase the risk of complication. While polymer jacketed and stiff guide wire can increase the risk of coronary perforation, workhorse guide wire are not completely safe either. Very frequently, conservative therapy can treat distal perforation. However, sometimes intervention is needed. Embolizing a portion of the balloon can be an alternative approach to other techniques. This method is fast, cheap, and is as effective as coil would be. Thank you very much.
Thank you, Dr. RB. Yes. Is there any comments or questions from panel?
Congratulations for your tough case without the coil situation. And then I have a question. What size of the balloon did you use for embolization to stop the bleeding?
I did not understand your question.
So what size of balloon did you use to stop the bleeding? I mean, you cut the balloon to stop the bleeding. Yeah, so what size did you use?
Apollo NC 30, 3.0.
3.0.
Yes.
So why did you use a 3.0 to make it sure the sufficient size to the PDA specified?
Yes.
Oh, I think it's quite a good technique. I didn't know this technique, so congratulations for your success. Very large.
So let me, I would like to comment that I think it's a tremendous case. The technique has been described, but it's and I'll tell you, this is beautiful. We use coils, obviously, and you asked as to how would you use a covered stent in such a situation if you had a covered stent. Well, the covered stent, as you know, will not go into that PDA. It's a very small size. So occasionally, if you do have a covered stent, then you can actually just stent across the side branch and then close off the side branch, provided it's not collateralized from the other side. So we've done that in cases of perforation of a small branch where we've not been able to close it for multiple reasons. Where the small branch had bled, very close to the ostium of its origin from the main branch, where a coiling would have resulted in coils coming into the main branch. And then you can actually just put a covered stent into the main branch so as to close off the side branch. But this is an elegant technique. The only fallacy here is that if you have a stenosis at the origin of the side branch, then you will actually have, you could get your balloon stuck without going into the side branch. And that's what you've got to be careful about, because then you'll have no way of bringing it back apart from putting in snares and coiling and other issues happening, because it can't be brought back. It'll then sit in the main vessel because it's not entered the side branch. So it's great for distal vessels, provided there's no stenosis in between.
Thank you for your recommendation.
Thank you for your nice presentation. And this target region is a distal part and a small vessel. So I agree with your plan, and this technique is very good for small vessel. And do you have other case using this technique? No, this is a first case.
Yes, yes, yes. I do 2 cases with this method.
I suggest you publish it.
Thank you. Thank you.
In 2 cases, is it easy to deliver the cutting balloon to the target part?
Delivery of balloon was challenging, especially in calcified and tortuous vessel. And one of the problems with its technique is delivering, especially in the small vessels.
Okay, thanks to the nice presentation, Dr. Arbi. From the next
Thank you.
cases, Dr. Seth will introduce.
Sure. So our next presentation is Intra-coronary Rendezvous Technique with RG3 for an RCA CTO with Un-crossable Retrograde Micro-catheter, presented by Cheng-Chun from the Xingkong Memorial Hospital in Taiwan. Please go ahead.
Good afternoon, all doctors and master operators. It's my pleasure to lecture here. Today, my topic is Intra-coronary Rendezvous Technique with RG3 for RCA PDA CTO with Un-crossable Retrograde Micro-catheter. I have nothing to disclose. The patient is a 65 years old man with hypertension, diabetes, and dyslipidemia. His chief complaint is stable angina for over 1 year. The Dian scan shows inferior wall severe ischemia. This is the control angiography. Yeah, the angiography showed RCA PDN branch total occlusion. And there is a dimple in the CTO entry site. Over here. And inside the CTO body, there are some calcification. There is also a very good connection from LAD septal channel to the distal PDA, like this view. We started with Antegrade approach with XTA and Corsair support. We also use IVUS to guide our entry puncture, like this. However, the CTO entry is very tough and hard, so we escalate our wire from XTA to Gaia series. But the hard tissue deviate our wire course, so our wire finally advanced into the subintimal space or even outside of vessel. Therefore, we decided to shift to retrograde approach. We use Sion wire with Caravel and successfully crossed the septal channel and to the distal PDA. We performed tip injection, and the tip injection showed the CTO exit was blunt. The CTO exit was also very tough. We used several stiff wire to puncture, And finally, our wire was advanced into the CTO body, like this. After some efforts, we made both wires overlap with each other, and we performed a reverse card technique over here. And we also used guide extension to pick up the retrograde guide wire into antegrade guiding catheter. Then we start to try balloon trapping technique. We tried a 2.5 balloon over here and tried to push the retrograde, which is caravel. But the caravel cannot cross the CTO lesion. So next, we try to rendezvous technique. We use caravel and to rendezvous the retrograde wire over here, like this film. After rendezvous was succeed, we try to push the antegrade micro-catheter across the CTO, but also failed. So finally, we tried another approach. We tried to put both micro-catheter as close to each other as possible. And we manipulate the RG3 directly across the antegrade micro-catheter. So after RG3 was externalized, we got very strong backup. So we start to perform balloon angioplasty. We start with 1.25 balloon, then upgrade to 1.5, 2.0, and 2.5 millimeter balloon catheter. However, a balloon indentation was found over here, even under very high pressure balloon dilatation. So we decide to perform a rotablator. Rotablation with 1.25 millimeter burr. After several rounds of rotablation, we repeated balloon angioplasty and deployed 2 drug-eluting stents. This is our final angiogram. And there was no septal channel damage. So our discussion point, when the retrograde micro-catheter could not pass the CTO lesion, rendezvous technique is always useful to pick up antegrade micro-catheter by retrograde wire. However, if this skill also failed, we have several options. The first option is we can change antegrade micro-catheter to toners and rendezvous inside the antegrade guiding catheter. And the other option is to use this scale, intra-coronary RG3 rendezvous. We have to keep both micro-catheter as close to each other as possible. And we have better to rendezvous at a curve point rather than straight vessel. Our conclusions are, we experienced a severe calcified RCA CTO case that stuck the retrograde micro-catheter, and we overcome the situation with intra-coronary RG3 rendezvous technique. Of course, this technique always takes the risk of losing wire. However, we believe once we cross the CTO, we may easily recross it again. I hope so. Thank you very much.
So that's an excellent case. Explain this to me. You said that the rendezvous is better on a curve rather than as a straight segment. I'd just like to understand that aspect of it firstly.
Yes, because the curve point, we can make some wire bias. It's much more easier to rendezvous at curve point rather than straight point.
Is that so? I mean, there you actually positioned the 2 microcatheters close to each other. That was the segment which could not be crossed by either. Is that correct? That's yes. The segment which could not be crossed by retrograde. And you put them next to each other, and then you actually made the wire go from one microcatheter into the other microcatheter. Is that
yes.
correct?
Yes, it's correct.
That's elegant. I mean, to get it into a microcatheter. Now, the antegrade microcatheter for the audience, the antegrade microcatheter was also caravel and the retrograde was also caravel?
Yes.
Okay.
Yes.
Do you think that if you'd taken a fine cross, would that have a better chance of crossing just because it's got a lower profile than caravel?
But in Taiwan, we have only fine cross MG. We don't have fine cross GT. So okay. I think success rate will be maybe lower. I'm not sure.
Okay, okay. Over to others, the other panelists, and of course my co-moderator. I'm sure they have comments and questions.
I have one opinion about microcatheter selection, and I agree with Dr. Seth. And in general, Caravel is a very good microcatheter for CTO PCI, including a retrograde approach. However, it is not so good for calcified region.
Yes.
Yeah, I think in calcified region, a fine cross is better than Caravel. Yeah. This is a special situation.
Thank you. Thank you much.
So I think with no comments, but I think it's a very illustrative case. It just tells us as to we should always have fallback options. And I'm happy that you actually presented that if this had not worked, what were the other possibilities? But I would also ask Dr. Hamazaki to actually say, if this had not worked, your next strategy seems to be that you would have used a fine cross. What other strategies would you actually have up your armamentarium?
Yeah, this is a very difficult situation in a calcified region. In some case, we cannot advance microcatheter from a retrograde side. As presenter said, RG3 direct crossing is a risk of losing guide wire position. So this method is a final strategy for me. And one option is Antegrade wiring using a hard CTO wire to make a crack in the CTO. In this, after using this method, in some case, retrograde microcatheter can pass. Yes, this is one option. Yeah.
Okay. Great. I think thank you very much. So that was very nice discussion, and we now go on to the next case, which is revascularization for CHIP. Low left ventricular ejection fraction patient with CTO, calcified and left main bifurcation disease. And that's going to be presented by Yongbai Luo from the first affiliated hospital of Xi'an Jiatang University in China.
It's my good afternoon. It's my great honor to the presentation my case. My topic is about revascularization for CHIP, low left ejection fraction patient with CTO, calcified and bifurcation disease. I'm Dr. Luo from China. Okay, I have last thing to disclose. This patient is 62 years old male, is CHIP complaint, exertional chest discomfort for 10 years, aggravated for 3 months. He has 3 vessel disease and right coronary and circumflex CTO and left LAD and diffuse and calcification disease. The turbulence is high and probability is high, and the echo shows the left ejection fraction is very low, just 22%. The diagnosis is lastemi and heart failure. This is coronary angiography. We can see very diffuse and calcification with LAD and diagonal is bifurcation disease, and the circumflex is total occlusion. And the right coronary is total occlusion, and we can see that from the mid segment, right coronary is total occlusion. The patient needs CABG, but because of the very low ejection fraction, the patient was refused by surgeon. So the patient need to do the revascularization. So we first arrange the CTA for this patient. We can see a very this right coronary is total occlusion, but we can't see calcification, maybe tortuous. From the angio, we can see some macro channel from the antegrade angiography. Also, we can see it's in the CTA. And from the septal, we can see collaterals from the left to the right. Maybe you can use it. And the CTA for the LAD, we can see very severe calcification for the LAD. So our strategy is first we do the PCI for the right coronary, then do the LAD and circumflex with LVAD. Right coronary we use antegrade. We maybe use antiviral expression or ADR. If antegrade it was failed, we need to treat the circumflex first, then do the LAD, then we use the retrograde to treat the right coronary. This is our first attempt. And we use the field XT to cross but failed. So we changed to the gas second and we cross the wire. Then we push that we dilate the lesion, then implant 3 stent in the right coronary. This is the final result. This right coronary is huge, and we can see it very well. A week later, we do the second PCI for the left coronary. Because of the low eject fraction, we use the impeller assistant. The cochlear cannot pass the LAD, so we changed one small balloon to dilate the lesion and change the one bankross to pass the lesion. Then we use 1.5 bar to do the localization for this LAD. Then we check the iris. We can see very severe calcification, but we can see crack in the LAD and reverberation. Then we use a cutting balloon to preparation this lesion. Then we check the iris again. We can see very much too much crack in the LAD. We can see all kinds of hematoma. According to the iris, we implant 2.5 by 20 line DS in the distal or ALD. Then this is the result. Then we open the circumflex. The circumflex is very easy by very XTA. After we predilation the circumflex, this is the result. Then we use one stent to treat the LAD and the bifurcation or the diagonal bifurcation with a gel balloon. And how to treat the left main bifurcation? From the iris, we can see there is a low good result landing zone for the LAD and for the circumflex. So we choose the mid-cross step cross to treat this left main bifurcation. And we verify the wire position. Then to do the final casing. This is final result. We can see the stent is very well, the expansion very well. This is from stock, and this is final result for this patient. And 10 months follow-up, the patient is good, and the left eject fraction was increased. So this is a home message. Complete revascularization is very important for patients with low heart failure. Usually, this patient received cabbage. Sometimes we use PCI. Careful analysis or image is key to success of CTO PCI. Ventricular assistant device are critical for chip PCI, especially for those with low left ventricular eject fraction. Intra-coronary imaging can provide more information, optimize results. Thank you.
Thank you very much for that elegant case, Dr. Luo. I think you have 2 or 3 important emphasis that you gave, which I totally agree with, which is that in cases with LV dysfunction and complex high-risk indicated PCIs, you have to achieve complete revascularization of all viable areas. And I assume that you actually therefore assessed viability in the RCA and the circumflex before you attempted those. And I'm sure you would have done viability studies for them. That's the first point. And second point that I wanted to make for you was Impella was correct And I didn't know you had impeller available to you in China at the moment, because there are some countries in Asia which still haven't got impeller. Was that an impeller CP, or was that a 2.5 that you used for revascularization?
I use 2.5.
You use 2.5.
Yeah.
Yeah, that's
CP.
You don't have CP. Okay, so
usually for in China we don't have impeller for the commercial use. Where this patient was the clinical trial, and yeah, that's right.
Good.
And we usually use that patient for the ECMO and combine with IBP usually.
Oh, right. So I pass it over to my colleagues, Dr. Park, yourself, and Dr. Hamazaki, Dr. Ko, your comments on this.
So in Korea, the impeller is not still available. So we are waiting for launching impeller. So in this case, what we can do is just use a bumping at first, and yeah, that's all.
Yes.
Yeah, in Japan, use of impeller is very limited by insurance regulation. So, and maybe we cannot use impeller in this case, but this is a best way for this patient, I believe.
So yes, we have been using impeller. In fact, the first ever the first ever live transmission of impeller to the main arena of the TCT happened with us at Delhi in India, with my transmitting it in 2007. So we've been using impeller since 2007, even before its FDA approval. This is the sort of case we would definitely use it, but I would suggest that I would have used a 3.5, because that's what provides the complete, a much better support than a 2.5. And especially when you're doing long LED, there are long bifurcations, there's complex disease, ejection fractions low, then the support is very important, especially if you get to the left main. And if you start doing left main bifurcations, you really need a 3.5. The 2.5 just provides slightly more support than an IABP. So that's the first point that I would actually make. What was the technique that you performed for the left main? That didn't come out clearly, Dr. Luo.
Yeah, because I was shown no good landing zone for the LED stent and for circumflex stent. We treat the patient with crash. Yeah,
that's right, and it was all IVUS guided. So that was great. Again, that's why I said that because you were on a trial, but if we had availability commercially, the CP would have been the best role. Yeah. More recently, we've had a single access impeller, as you know. We've been able to do it through a single access, which means the guiding catheter also goes through the same sheath as the impeller catheter.
Okay.
Any other comments and questions? Okay. With that, I think we can proceed to the next case, but very elegant, and I think it was a very complex case. So much congratulate you and your colleagues for an excellent revascularization in a very difficult subset. And I'm sure you've given him a great result and a great outcome for a longer period of time. So we move on to the PCI of the left anterior descending artery CTO through left internal mammary artery graft. The case is going to be presented by Dr. Amreen Dhinsa.
Good afternoon, everybody. I'll be presenting this case on behalf of Dr. H.K. Bali. He is stuck in the cath lab, and our apologies for that. This is a PCI of a left anterior descending artery CTO through the left internal mammary artery graft. CTO tackling remains a huge challenge for interventional cardiologists till now and accounts for almost 10 to 20% of all PCIs, but lately the PCI of CTO success rate has improved remarkably over the last decade. So our case is about a 73-year-old male who is a known case of type 2 diabetes, coronary artery disease. He underwent a CABG in 2007 with a Lima graft to the LAD and an SVG graft to the obtuse marginal. He presented with chest pain and shortness of breath. The ECG was normal, the echo was normal. A CT coronary angiography was done, which revealed a patent SVG2-OM graft and a patent Lima graft with a diseased LAD beyond the anastomosis. So this is the coronary angiogram, which shows the retrograde filling of the distal left anterior descending through the left injection. Sorry, there's some problem in the slide. Yeah. So we could see the left internal mammary graft, which is patent, and there is cutoff beyond the anastomosis. So we decided to do the antegrade Lima, through the Lima, the antegrade approach to treat the distal LAD CTO. We took the right femoral arterial route. The guiding catheters used were 6F XBC3, and we used Asahi micro-catheter Corsair. BMW and Shinobi wires were used, and Zion's Expedition stents were deployed. So initially, with the help of a micro-catheter, the BMW wire was used to reach the lesion. The BMW wire was exchanged with the Shinobi wire, and the lesion was crossed. Pre-dilatation of the lesion was done with a 1.5 into 15 mm balloon, followed by a 2 into 15 mm balloon. After the pre-dilatation, the antegrade flow was established. After this, a 2.25 into 28 mm drug-eluting stent was delivered. The stent was deployed in the distal left anterior descending. A 2.5 into 33 mm stent was deployed from the Lima graft to the LAD. And post-dilatation was done with a 2.5 into 10 mm balloon. So this was the final result which we achieved. So there was a TIMI3 flow in the LAD and the distal LAD, and the Lima, the stent was deployed through the Lima graft into the distal LAD using the antegrade approach. So to be successful in tackling a CTO lesion, one has to be proficient in both the antegrade and retrograde techniques for CTO. Antegrade CTO PCI of a native coronary artery via a Lima graft is rarely performed, and few cases have been reported worldwide. And our case demonstrates that the PCI of a native coronary artery through a Lima graft antegradely is feasible and safe option in patients with chronic total occlusions. Thank you.
Thank you very much, Dr. Dinsa. And this is now open for discussion amongst my colleagues.
Can I ask the access site regarding access site? Why did you choose a femoral artery? Because regarding the backup force of the guiding catheter, it's better to use a left brachial artery or something. Why did you choose a femoral approach?
So a lot of the choice of approach also depends on the comfort of the operator, and usually it is the radial or the femoral approach which we use, and in complicated cases in which we can expect complications, we usually go through the femoral approach in our centers.
Thank you.
As Dr. Go talked about the approach site, sometimes if the left radial artery was available, sometimes the guiding is much safe proceed on the opening of the rim artery. So the left radial approach is another option in such a situation.
So, Dr. Dinsa, so, you know, a lot depends upon the tortuosity of the internal mammary artery in such circumstances. You seem to have had an internal mammary artery which was a straighter segment. It was fairly straight, which is unusual for tortuous internal mammary artery, and you were able to deploy even 33 millimeter long stents through that internal mammary artery. So that's one of the advantages that you had when attempting this, because as we all know, the way the surgeon puts these arteries, that there's such loose bends that if you have a couple of circuitous bends, then attempts to get long stents down can actually create dissection of the left internal mammary arteries. And therefore, it's not just getting the equipment down, but the traction that you create on the internal mammary arteries which causes the dissection. We've had extensive dissections which go all the way up, closed up to the ostium, and on the curves especially. So that's one thing to be taken care of. On the other hand, I think we didn't get a clear picture of why the attempt was not possible through the native LAD. And that's the other question which one asked. Was there no path through the native LAD? Was an attempt possible on that route? Why did you take the internal mammary artery route?
So the native LAD was actually initially what we had attempted, but since it was not possible, then a decision was taken to go through this approach.
Okay, excellent. So that's the great. What are the stents that you actually got down, the 33 and the 28? That's a long segment of stenting.
So the Zions expedition stents were used.
Okay, so you know yourself that those are less flexible stents, and perhaps your straight segment, the lima, was more straight than others, which made you take these things down with proficiency.
Yes.
And finally, the important aspect for others is that when we work on the lima and we work at the anastomosis site and downstream, we always forget the ostia of the lima, which is not under our view and vision. That is why one of my other colleagues suggested using the left radial route, which actually gives you much more coaxial intubation and support of the left internal mammary ostium. On the other hand, the dissections at the ostia are commonest when you actually try to work way down the LAD. And therefore, one of the good ideas sometimes is to keep a wire in the subclavian, a second wire in the subclavian, which stops enforcing your lima into the ostium of the lima, only apart from when you actually need to intubate the lima for the purposes of support.
Right.
And that's an important aspect. And the third important aspect I would say is that occasionally it's better to get a guideliner down the proximal segment of the lima so that you actually have a better support down the lima while actually working on the distal LAD through the lima, because those are softer catheters. Any other comments? So I think if there are no other comments, it's time to sum up. And thank you very much, Dr. Dinsa. You've been very excellent. And I know that your chief is actually in the cath lab, so you've had to take all the questions, but congratulations for answering all of them.
Thank you. Thank you. Thank you.
So I think we've had a great session. I think there have been tremendous cases. It's been worthwhile for all of us, along with my co-moderator, Dr. Park, to sit through these. And these are very illustrative. I mean, some wonderful, I would say, tricks and tips around CTOs came from Dr. Setiawan from Indonesia, when he had the rendezvous of the two. He used the trapping technique to get retrograde equipment through the total occlusion retrogradely. Yes, a very important technique always for us to remember and utilize. We also had some great presentation of rendezvous technique by Dr. Chun-Wai, again, of an uncrossable CTO, which could not be crossed antegradely or retrogradely, and then a rendezvous was done within the total occlusion using 2 microcatheters and then an RG3. I think it was also antegrade technique through the internal mammary artery of revascularizing a CTO of the LAD beyond the anastomotic site was an excellent case. We've had some great tips from Dr. Alavi around dealing with distal wire-related perforation using a very elegant, easy methodology of cutting a balloon and just shoving it downstream into the small vessel, leading to embolization. I think it's a technique for all of us to remember because it hardly costs anything. And if you've got a straight entry without any lesions in between or any calcified tortuous segments in between, we would be able to utilize this technique much more frequently because it's cheaper and move faster than coils, which sometimes do require to them to be on your shelves for the small coils to be on your shelves for small vessels. So thank you, Dr. Alavi, for telling us this. And then, of course, we had an excellent CTO, chip CTO case and triple vessel revascularization from Dr. Luo, reminding us that in impaired left ventricular functions, when you take them up for revascularization in lieu of surgery, complete revascularization with safety is the most important aspect. You want a patient who's alive and who's been revascularized completely to expect his LV function to improve and therefore give him the best outcomes. And I think that was elegantly demonstrated. I think we've had a great session. I hand it over to my co-moderator for anything that he's got to say. So Dr. Park, any final comments from yourself?
Thank you for all. And this was a wonderful session, and all of us and rest of the listeners will join the rest session of the complex PCI. Thank you.
Thank you very much, all of you.